states nomograms for selecting patients for active surveillance. So before we kind of get into the background of this, I just want you all to consider a clinical scenario. You have a 65-year-old Caucasian male, no history of prostate cancer in the family. He comes in, he gets a PSA, let's say it's 4. Comes in 6 months later, it's fine. What do you do? Most clinicians are going to go ahead and give this patient a prostate biopsy, whether it's a MRI-based prostate biopsy or a standard extended sexted crust biopsy. He's going to get a biopsy. The path report is going to come back, and depending on what the path report is, you're going to have to make some decisions. And is that, are you going to treat the patient or are you not going to treat the patient? So keep that in mind as we go through this. So prostate cancer classification, histopathologically, when you're looking at single cell architecture, they're stratified based on grade, and the lowest grade that a cancer cell in the prostate has is 3. Gleason scores are some of the most prevalent and second most prevalent Gleason patterns, but not all Gleason scores are the same. So a Gleason score 7 could either be 3 plus 4 or 4 plus 3, but the 4 plus 3 disease is going to increase the mortality in that patient 3 times in comparison to the 3 plus 4 disease. Staging, clinical stage 1, you can't feel or see the tumor, but you find cancer usually through a crust biopsy. And stage 2, the tumor is confined within the prostate. The substages of that are based on how much of the gland is actually involved. Okay, so the path report on this patient comes back, and you're trying to figure out, should I operate, should I not operate? And you don't want to operate on insignificant disease or disease that's not going to hurt the patient. So how do you make the decision whether or not it's an insignificant disease? Well, here is a very busy slide, but you can see there's no single definition of insignificant disease, and this makes this clinical decision making much more difficult. Although there isn't one single definition, one that many clinicians use, the Epstein definition. This is the definition of insignificant disease on whole mouth pathology, but we're kind of moving away from this. This criteria may be too strict using current technologies. A lot of times in the papers now you'll see authors reporting a Gleason score of 3 plus 4 as insignificant if it has less than a certain number of, or a certain percentage of the core is Gleason grade 4. Or some clinicians even say that Gleason grade 3 plus 4, no matter the percent Gleason grade 4 in the core biopsy available, is insignificant. So defining clinically insignificant disease is something that no one, the entire field is not, I guess, on the same page about. So what is active surveillance of the prostate? This is postponing immediate therapy. So if a patient comes in, he's got low-grade disease as seen on the prostate biopsy, you don't need to treat him right away. You don't want to necessarily over-treat the disease because there's side effects to treatment. And you can go ahead and follow the disease and catch it before it gets too aggressive, treat the patient at that time. So what's the rationale? So growth of prostate cancer is slow and it's constant over time. And having prostate cancer confined to the gland does not give a specific morbidity or mortality to the patient in and of itself. You can go ahead and monitor the disease, and like I said before, give treatment when necessary. And as I said before, all treatments have side effects, whether it be incontinence, erectile dysfunction, stricture. You don't want to be putting patients through that unless they really need to. So how do you, based on a prostate biopsy, how do you predict what's going on in the gland as a whole? Well, there's been developed this Epstein criteria, and the Epstein criteria is just a bunch of clinicopathological parameters that were put together that allow you to have confidence on what the actual grade of the disease within the prostate is. Is it significant? Is it not significant? When this Epstein criteria first came out, it showed about 94% predictive ability for predicting insignificant disease. Validated studies by Bastian et al. Showed about 84%. And then I included some other criteria that are available. And so, not only is there not a single definition for insignificant disease, but there's multiple criteria that surgeons or clinicians need to choose from when deciding whether a patient has insignificant or significant disease. So what are the problems with some of these rule-based selections of patients? Well, it's a simple combination of inclusion criteria, and so you get this binary outcome. High probability of disease, or high probability of insignificant disease, or low probability of insignificant disease. And the problem with these simple binomial outcomes, or binary outcomes, is a lot of times a low probability becomes the patient has significant disease. So maybe the patient doesn't meet all of these parameters for the Epstein criteria, so he has a low probability of insignificant disease. That becomes he must have significant disease and he must have surgery. So you're over-treating these patients. So how can we do it better? If we're not using these criteria-based solutions, how do we use a probabilistic method? Well, a probabilistic method is more personalized, it's more refined because you're actually assigning a quantitative value to it. So the patient has a 60% chance of insignificant disease. This can help guide active surveillance selection. A nomogram is a form of, or is a type of probabilistic method. So what is a nomogram? Here you can see on the left side patient parameters, and depending where the patient falls within these range of parameters, you assign a point value. So here we're assigning point values. You add all the point values up, and that gives you a probability of insignificant disease. Okay, so we've developed our predictive model with our parameters of interest. Now we're interested in determining how well does our model actually work for discriminating which patients have insignificant disease and which ones have significant disease. So some basic stats that we all might remember. The takeaway message from this is sensitivity and specificity are measures of a test validity. You can think of the true positive rate as identifying patients with insignificant disease, not treating them, so you're benefiting the patient. You can think of the false positive rate as incorrectly identifying patients as having insignificant disease, and thus not treating them when they should be treated, and then you're harming the patient. So remember that sensitivity and specificity are inversely proportional to each other, and so it'd be interesting to see how our model functions as we move from the threshold max down to the threshold min. And we can do that, and as we do that, we develop the receiver operator characteristic curve. And you can see our threshold max here, and our T min here. So this is plotting as we move from T max to T min. Ideally, we want our model of interest to quickly move up to T max, because that way we're getting a high number of true positives while decreasing the number of false positives. Our random model here is as though we're flipping a coin, and so we can go ahead and take integration of of each of these curves to find the area under the curve. And this is a function of how well the model can actually discriminate. An AUC of 0.5 is the same as just flipping a coin. You want your model of interest having AUC between 0.5 and 1. Okay, so as we continue to move forward, remember that radical prostatectomy, whole mount specimen histology is the only way to evaluate true cancer burden within the clinic. So here is our paper that we're going to be going through. This is from Prostate Cancer and Prostatic Disease, which is a subsidiary of Nature Publishing Group. And in a nutshell, they created receiver operator characteristic curves for 4 different predictive models. And then since there is no defined or no definition for insignificant disease, they saw how well these different models could discriminate between 4 different definitions. They used patients from 3 international centers, and these N values are actually pretty high considering that you want to be taking samples of patients who that could be put on active surveillance but choose not to. They don't like having the disease in their body, so they choose to have radical prostatectomy instead. So these are actually pretty high N values considering that patients didn't necessarily need to have surgery, but they chose to. So here are the 4 different nomograms that were looked at: Tons, Dyer, Chun, and O'Brien. These are kind of the standards that are used today. There's some others, but. And here are the AUCs that were originally reported by each of the models. You can see it's pretty good. anywhere from 0.8 to 0.95. And, we'd be very happy with the Chun and O'Brien models because those are close to 1. And then here's the 4 different diseases, or definitions of insignificant disease that were applied to each of the models. As you move from definition 1 to 2, you become less stringent by increasing the volume of disease that's allowed to be considered insignificant. As you move from 2 to 3, you just remove any type of constraint as far as volume. As you move from 3 to 4, you're allowing a larger Gleason score. Okay, so here are models of interest with the AUCs, and this is using the Epstein definition of insignificant disease at radical prostatectomy. And you can see that the AUC values are not good. They range from 0.56 to 0.63, and that's, considering that these models were all designed to predict Epstein definition of insignificant disease at radical prostatectomy, we'd expect them to perform a lot better. They're a lot different than what they originally reported. 0.8 to 0.95, they're much lower than that. Using a less stringent definition for insignificant disease, you can see again that the AUCs range from 0.58 to 0.66, not performing that well. Even a less stringent definition, 0.54 to 0.58 is the range of AUCs. And using the least stringent, the Gleason score less than or equal to 3 plus 4. AUCs, again, are very low, 0.53, 0.61. Not what we were hoping for these nomograms, these predictive models to be able to discriminate. They're not doing a good job discriminating those patients with insignificant disease from those that have significant disease. Here's a table showing the Breyer scores. The Breyer scores are basically just a second way to evaluate an nomogram's ability to discriminate between patients with insignificant and those with significant disease. The Breyer score is inversely related to the ability to discriminate. So you can see that the Baton, a model, can best discriminate using the Epstein definition for insignificant disease based on the lowest Breyer score here of any of the other definitions. These are calibration curves. This is just a representation of the agreement between the prediction of the nomogram and the actual observation. You can see that the range of probabilities that the Baton model can predict over using these definitions is actually, fairly good, 10% to 70%. While the other models have very low accuracy, all of these are less than 40%. The curves are almost shifted to the left, and one reason for that is because they include a high rate of patients that have significant disease. So the Chun and the O'Brien model, the patients that actually had insignificant disease was less than 5%. And so you almost underpowered the study. And the high AUCs that were originally reported by each of the models wasn't due to discriminative ability, it was actually due to a low pretest probability. Decision curve analysis showed that the Baton model was no better than assuming no patients have insignificant prostate cancer. And so which variables were significant for predicting Epstein insignificant disease? That was lower PSA, younger age, and a lower prostate volume, as evidenced by a p-value less than 0.05 and 95% confidence interval, not including one. Okay, so there's only one study, Stamatakis et al., 2013, that was done here at the NIH, and it used only MRI-based parameters within its prediction model, and they reported an AUC of 0.71. There's a couple of problems with this study, however, is because they used lesions on MRI as an endpoint. This is not a validated endpoint. Remember, the only way that you can actually look at disease burden is on whole mount pathology, with a reading from a pathologist. And MRI misses 10% of high-grade lesions, so there's an intrinsic positive bias in using this as an endpoint. Additionally, there's been no multi-center studies to validate this either. So, what are the take-home points? External validation revealed modest performance at best. All of the models lacked ability to identify men with a high probability of insignificant disease over 4 different definitions of insignificant disease. And all predictive models must be carefully validated because all that clears is not gold. So to answer our clinical question, does MRI-based nomograms do not outperform classical clinicopathological-based nomograms for the selection of patients in clinical surveillance? I want to give special thanks to the whole team, and especially Dr. Lightman, Kenny, Tony, and Red.